It's now my pleasure to give the next talk, What Did We Do Right? A Perspective from the Global North. You've heard already in the first two talks that there were many things that we did wrong, and I think it's important that we acknowledge those mistakes and learn from them. But it would be a mistake not to also acknowledge that some things went right. Now, I don't at all intend to imply that the things that were done right were distributed equally or equitably, or that they couldn't still have been done better, but we should at least acknowledge some of our successes. These are my disclosures. So I will quickly, in the next 10 minutes or so, review what I think, from a biomedical perspective particularly, was done properly and done throughout most of the North. And this included the application of molecular epidemiology, infection control, healthcare mobilization, diagnostics, therapeutics, the implementation of randomized clinical trials, the development of vaccines, communication, and community engagement. With respect to molecular epidemiology, there was rapid sharing of sequence information from the original Wuhan SARS-CoV-2 strain that enabled the development of both molecular tests and vaccines. Indeed, within a day of the sequence first being released, several manufacturers around the world began work on a vaccine. The sharing of sequences through GESIDA ensured global access to these sequences, and the development and then propagation of full-length sequencing of SARS-CoV-2 allowed identification of novel variants as they arose in near real time. Quantitative sampling of sewage allowed prediction of trends in clinical cases, often predicting when there would be upswings and downturns in COVID-19 as the pandemic rolled out. And at times, the sewage itself could be used to identify novel variants. There were many things done correctly with infection control. The masking of staff and patients sharply curtailed nosocomial transmission. This was clear in my own hospital. And COVID-19 incidence among hospital staff was consistently lower than incidence in the community at large. PCR screening of patients for SARS-CoV-2 allowed isolation or cohorting of patients as appropriate, further reducing the risk of acquiring SARS-CoV-2 among vulnerable patients in hospital settings. And the use of appropriate personal protective equipment and its reuse, the extended use of PPE as appropriate to augment supply when the supplies were tight, was another rapidly implemented innovation that helped to keep the hospital staff protected. Widespread adoption of masking contributed to lower rates of COVID-19 in communities with high adherence to masking, but as we know, the adoption and adherence to masking was really quite spotty and therefore can only count as a partial success. And then improved ventilation and HEPA filtration played a role where these innovations were actually implemented. What about acute care for hospitalized patients? Hospitals in the North mobilized rapidly to expand the number of intensive care beds. Staff redeployed to support the demand for ICU care. In my own hospital, which has approximately 600 beds, we ended up having approximately 100 ICU beds, which was a five-fold expansion in the number of beds that we typically have. The creation of field hospitals to meet the demand for beds expanded this capacity as well. Within hospitals and hospital systems, a centralized coordination of efforts through incident command structures played a vital role in assuring the coordinated function of each component of the hospital and of the healthcare systems. The pivot to virtual patient encounters for non-acute outpatient care was an essential adaptation that allowed for ongoing care of people not able to access care in their usual settings. And the commitment of staff to provide care despite the risk to themselves really needs to be acknowledged, both for the heroism of those staff and for its impact in our response. The rapid development and deployment of validated molecular tests, both by PCR and then later through point-of-care antigen detection for home testing, was a critical innovation that really made a crucial contribution to our ability to identify who had SARS-CoV-2 infection and when people might be able to return to the workplace. The availability of testing enhanced our surveillance and infection control efforts. and semi-quantitative PCR tests became important laboratory markers for early phase testing of antiviral therapeutics. Turning to therapeutics, the rapid development, testing, and deployment of therapeutic interventions was really extraordinary. This included not only antivirals such as remdesivir, the combination of nirmatrelvir and ritonavir, molnupiravir, and various generations of monoclonal antibodies, but also immune modulators, including dexamethasone, tocilizumab, sarilumab, baricitinib, and so forth. The use of various mechanisms to accelerate the regulatory authorization, such as emergency use authorization in the US, speeded access of populations in the North to these important therapeutic interventions. And government purchase and distribution of these agents also assured widespread access, although frequently in an imperfect way. I can't stress enough the importance of randomized clinical trials. The rapid design and implementation of such trials, particularly the development and implementation of platform trials, provided crucial evidence that was essential to guiding our therapeutic management of SARS-CoV-2 infection. Often these trials leverage national infrastructure, such as the National Health Service in the United Kingdom and the National Institutes of Health clinical trials networks in the United States. There was also the innovation of implementing remote trials in the outpatient setting, studies where no participant ever had contact with any investigator in a face-to-face setting, and the importance of negative trials in curtailing the use of ineffective agents cannot be overestimated. And I'll just show two data slides here. First, this is the study showing the importance of dexamethasone in reducing mortality, which came from the recovery trial, one of the first studies to show a mortality advantage. And then this series of negative trials looking at metformin, ivermectin, and fluvoxamine as ineffective, helping us to direct our efforts and focus our efforts on the truly effective interventions. Now, of course, the most important advance and the greatest success was the development of vaccines. One can't underestimate again the importance of the basic science work that laid the groundwork that made rapid development of SARS-CoV-2 vaccines possible. This included the development of RNA vaccine platforms and the adenovirus platforms. It also included work that had been done in other viruses, understanding the importance of the locked conformation of the spike protein as by analogy to work that had been done with RSV and with HIV. There was also the importance of private-public partnerships. Many of the trials that went forward to validate the vaccines and to demonstrate their efficacy were done with government funding that augmented the funding made available by the pharmaceutical companies or vaccine developers that had initially discovered these vaccines. There was also, as has already been alluded to in the previous talk, the importance of advanced purchase commitments to de-risk the trials and to de-risk manufacture. By committing to purchase vaccine, without knowing what the outcome of the trials would be, meant that once a vaccine trial demonstrated efficacy, there was already sufficient supply available to begin its distribution and implementation. Again, that was not a perfect distribution because it focused principally on those countries in which these trials were conducted, but it certainly accelerated the widespread availability of vaccines in the global north. We heard in the previous two talks as well about the importance of communication, and there were many examples of timely, understandable, and evidence-based messaging, which unfortunately were all too often muddied by politicization of those messages. But public access to COVID-related publications by the major medical and scientific journals was really an important benefit that really accrued internationally. There was also, for the most part, at least in the United States, frequent, generally accurate reporting by what I would refer to as the mainstream media, venues like the New York Times, even the Wall Street Journal, CNN, and most of the local media, as opposed to the fringe media who continue to confuse things. And as Anders mentioned already, it was important, and as Elena mentioned as well, it's critically important to be preparing the public for change, because we were learning as we went, and it was inevitable that there would be mistakes made that needed to be corrected. And this frequent appearance of scientific experts and local health experts on local and national media helped to convey those messages. There was also, and still remains, the need for effective means to counter disinformation. Lastly, one can't stress enough the importance of community engagement. It's essential to engage community in all aspects of the pandemic response, to have culturally appropriate communication, to partner with community to engage marginalized persons, and to address stigma, which became so important in convincing individuals to accept testing and to accept vaccination in order to be able to control the pandemic and to reduce the number of cases. The very last point, which I realize I hadn't included since my perspective is largely biomedical, but the comment by Anders in his talk reminds me of it, is that in many countries in the North, the countries did provide economic support for those segments of the economy and for those industries that were most hard hit by the pandemic in order to sustain individuals throughout the period when there were shutdowns in place and people were unable to work. Those could have been done much more effectively and more broadly, but they did help prevent a more general economic collapse in those countries where these interventions were available. So with that, I'll thank you for your attention